Hello everyone, what's up and welcome back to A Needle in a Haystack, a behind the scenes account of a mucosal melanoma survivor. I'm Chris White, mucosal melanoma survivor, thriver, advocate, inspirational speaker, and self-published author of Killing Cancer with Tills. Real quick before we get started, quick disclaimer, I am not a medical expert. I am only an expert on my own story and my experience. Therefore, please defer all your medical inquiries to your care team. All right, let's get started. Okay, picking up where we left off from episode 3, here in episode 4, we're going to go over some of my scan results. Starting off with the CT on the afternoon, evening of August 6th. It's a CT of the abdomen and pelvis, both with and without contrast. Here are the results. Impression: stable post-treatment changes in the pelvis without evidence of recurrent or metastatic disease. This is the comparison scan to the PET CT dated the month prior on July 11th, 2018. These are the findings. The visualized lung bases are clear. No focal lesions are seen within the liver or spleen. The pancreas and adrenal glands are unremarkable. The kidney function without hydronephrosis. Postoperative changes in the right inguinal region are improved. A linear area extending from the left perianal region into the left ischio-rectal fossa remained stable on CT and appeared non-FDG avid on prior PET scan, suggesting an area of scarring or treated disease. Okay, next up, following the CT, I had an MRI of the abdomen and pelvis with and without contrast. These are the results. Impression: number 1, baseline MD Anderson MRI evaluation. Number 2, faint focus of enhancement of the right perianal region, presumably the site of the known primary tumor. Number 3, no definite evidence of pelvic or inguinal adenopathy, post-surgical changes in the right inguinal region. Number 4, small lesion in the right lobe of the liver, somewhat small, characterized, probably a cyst. Moving down to the comparison, no previous MRI for comparison. Comparison is made to a contemporaneous contrast enhancement CT abdomen and pelvis dated August 6th, 2018. Note, this is the scan I did just prior to this MRI. And an outside non-contrast PET CT dated July 11th, 2018. Findings: there is a 1 centimeter T2 hyperintensity in segment 7 of the liver, series 10, image 11, somewhat small to characterize, without definite post-contrast enhancement, likely a cyst. No definite focal liver lesions are identified. The spleen, pancreas, and adrenals are unremarkable. No focal splenic lesions or splenomegaly. Both kidneys appear unremarkable. No hydronephrosis. The gallbladder is contracted. No evidence of biliary or pancreatic duct dilation. No abnormally enlarged retrocrural anterior diaphragmatic retroperitoneal or mesenteric nodes are identified. There is a faint focus enhancement in the right perianal region, post-contrast series 21, image 82, possibly the site of the known primary tumor. An incompletely imaged linear structure is noted in the left adductor region, extending to the left perianal and levator ani region, axial series 12, image 25, coronal series 13, image 23, of uncertain origin. No abnormally enlarged pelvic or inguinal nodes are identified. Post-surgical changes are noted in the right inguinal region. No definite left gluteal muscle lesion identified. The visualized skeleton is unremarkable. Okay, after an extremely long day on August 6th, August 7th, I started off the morning with a couple of ultrasounds on my groin. Here are the results. Ultrasound lower extremity limited left, ultrasound lower extremity limited right, August 7th, 2018. Impression. No pathologically enlarged lymph nodes identified in the left and right groin regions. This scan is a comparison to the PET-CT of July 11th, 2018, as well as the CT of the abdomen and pelvis dated August 6, 2018. Note that is the scan the evening before. Findings. In the left groin, there are benign appearing lymph nodes with fatty hilla. There is one lymph node in the right groin that measures 6 millimeters in short axis dimension that is overall stable in size since PET-CT July 11th, 2018. No hypermetabolic activity in the left groin was noted on PET-CT. No suspicious nodules, masses, or fluid collections in the right groin. Postoperative changes are noted. Benign appearing lymph nodes are present. No suspicious nodules, masses, or fluid collections. Following the ultrasound on the morning of August 7, 2018, I had a sigmoscopy scheduled for just shortly after lunch. Now, it was described to me essentially what this type of procedure is, but honestly, I really had no clue what to expect. I was told it would be like a colonoscopy, which I had never had up to that point, but I'd heard about instead of going under anesthesia and having to do the whole prep, I would just be having to do some enemas.
I think we're probably going to flex sig you today. Did anybody tell you that?
No, I don't know.
That's what
Take
he
a
mentioned
look
yesterday.
at your bottom.
Oh, okay, yeah.
Okay. So tell me how all this got started. I know you're probably tired of telling that story.
Yeah. Had this like lump in my groin and I went and got it checked out, and doctor thought it might have been a lymph node, and then after some medication didn't think it was a lymph node, so he had me see a surgeon, and the surgeon thought it was a femoral hernia. So he did an operation when he got in there, so it wasn't a hernia, it was a lymph node, and it was dead, so he sent it to biopsy, and then later on that week, I went to go get this hemorrhoid looked at, and the doctor's like, "I don't think that's a hemorrhoid. What's your pathology say?" And then, like, in the next day or two, I got my pathology back, and then went to an oncologist and got a bunch of scans and tests done and everything, and then came down here, started, came back down here, and been hanging out here for 2 days,
Okay.
getting a lot of stuff done.
Yesterday?
Yep.
What did he say? What was his plan?
He told me to get a CT scan and then an MRI.
Uh-huh.
And then an ultrasound. He didn't say, like, go sit in your MRI machine for an hour and a half, but I did it. No, but he told me to do those three things, and then come see y'all today. And then I already had an appointment to see the radiologist this afternoon, and then tomorrow to see what he thinks that we should do
Okay.
with treatment.
So medical melanoma is going to make the decisions on the next step?
I think so.
Okay.
Yeah.
But we need all of you to talk before we meet with Don so that he will know what that treatment plan is.
Well, I think Dr. Wood's role is to take a look at it.
Yeah.
Take a look at your anal area, because we don't treat melanoma.
No.
Yeah.
That's,
I just wanted him to look at it and get his opinion.
Mm-hmm.
Yeah. What I'm doing now is I'm going to go on and get consents.
Mm-hmm.
Okay, like I said, I did not know what to expect, but I finished my last enema and then did the procedure. So this is the results from my flexible sigmoidoscopy. Indications: anal rectal cancer or anal rectal melanoma. The medications was 2% lidocaine jelly. That was it. I had no sedatives, muscle relaxers, pain meds, benzos, anything like that. And I was still recovering from that prior surgery on my rectum. Here's the procedure description. After informed consent was obtained, the patient was placed in the left lateral decubus position. I was on my left side. External, in the right lateral quadrant, there is a healing area about 1 centimeter by 5 millimeters. On rectal exam, no mass is noted. Subsequently, the flexible sigmoidoscopy was introduced to 15 centimeters. The prep was good. The instrument was slowly withdrawn. On frontal view, there was a pigmented area just proximal to the denite line. Reverse maneuver was performed. There was about a 1 centimeter area of pigmentation in the distal rectum / anal canal area involving about 35 to 45% circumference. I tried to biopsy both in frontal or reverse view, but patient was too uncomfortable, so I could not. The instrument was withdrawn. The patient tolerated the procedure well. Findings: there was an area of granulation about 1 centimeter in length and 5 millimeters wide in the right lateral quadrant. The digital rectum exam was normal. Pertinent negatives include no palpable rectal lesions. On frontal view, there was the pigmented area just proximal to the denite line. Reverse maneuver was performed. There was about a 1 centimeter area of pigmentation in the distal rectum anal canal area involving about 35 to 40% circumference. I tried to biopsy both in frontal or reverse view, but patient was too uncomfortable, so I could not do biopsies. Complications: no immediate complications. Estimated blood loss: none. Post-procedure diagnosis: no specimens collected. Recommendation: discharge patient to home. Resume regular diet. The findings and recommendations were discussed with the referring physician. The patient will see the radiation oncologist today and the medical melanoma tomorrow. Okay, so due to the discomfort of the procedure, they did not get any biopsies, but they were able to determine that there was still some pigment within my rectum. And so to further investigate, we needed to set up a colonoscopy so they could sedate me. I'd be under anesthesia, take a nap. And the next available was on August 10th. You got to remember, this is August 7th. So the remainder of the afternoon on August 7th, I had an appointment with the radiologist to go over what their role would be. Following day on August 8th would be to meet with the medical oncologist to go over the entire plan as a whole after we had met with everybody that we had suggested we meet with and kind of get an idea of what was going on. So keep following along. I appreciate everybody. And up next is the appointment with the radiologist. Thank you.
Oh, all right, full crew here.
Sir.
Mr. White.
My brother.
Hi, nice to meet you.
I'm his dad, Jim.
Hi.
And his mother, Kathy.
Hi, nice to meet you. Do you want to sit?
No, you're fine.
Okay. All right. So I am one of the radiation doctors here that treats melanoma. So we were asked to see.
Yeah.
Kind of on the team.
Right.
And so they asked us to kind of weigh in about the role of radiation in your care.
Yeah.
But before we get there, I kind of first wanted to hear from you how you've been doing since the surgery.
Since the surgery for the lymph
Both.
node or both of them? Well, like the first one, within a week I was good again. I think there's like some nerve damage on the inner thigh or whatnot, but that seemed to heal real well and everything. And then the second surgery that I had on my rectum, the first day or so you're good because you're still numbed up. They said go home all jacked up, feeling good. Man, and then about
then it
for
hit
a
ya.
week it just sucked. It sucked real bad. And then The past week it
From a
felt
pain wise, you mean?
pain standpoint and everything, and then you know, you could kind of feel it healing and everything, and the pain kind of went with that, and so kind of just tapered off and everything up until that dude was trying to give me that second enema downstairs, and
Is the last doctor?
yeah, and then, you know, they were doing that scope thing or whatnot. Told them I would have taken a Xanax or gotten real high or something. Man, I wasn't expecting that, dude, but, you know, that kind of hurt a little bit or whatever. But, I mean, for the most part, I mean, everything's back, you know, just all normal. It's all
Bowel
good.
movements are normal?
Yeah, those
Okay.
are back to normal and everything, so
Okay.
appetite's good.
Not constipated?
Nah, never.
No. Pain is pretty much resolved?
Yeah, until, like, it gets some, you know, wanted, like, you know, fun going down from the doctor. You know.
Right. Bleeding?
No bleeding.
All right. Energy wise, you feel good?
Yeah.
Weight loss?
No, I actually gained weight.
Recently?
Well, just a little bit, you know, because I've been
less exercise and
Yeah, not being at work and more, you know, just availability to eat all day. or
yeah,
whatever.
diet's changed a little bit. Okay. All right. So what is your understanding of kind of the plan after? I mean, I know you've met a lot of people.
Yeah. So the plan was going to come down here, see you today, talk with everybody that I've seen,
Yeah.
and then he kind of lays out, like, do I need surgery? Do I not need surgery? Like, radiation. When do you start radiation? What does that entail? And then
Yep.
you do, you know, with the chemo and immunotherapy, and then, like, all the
How to
treatment,
sequence everything.
how to sequence everything, and what's possible side effects, and, you know, all that kind of planning and whatever.
Did the doctor? Did their team mention a role for additional surgery?
It's possibly because they, when he was up there scoping, he found something. He was trying to biopsy right there, but due to positioning and comfortability and pain and all that, he's going to talk to Jeff and see what he wants to do. But if they wanted the actual biopsy of that, they'd have to sedate me.
Yeah, examine anesthesia.
But they're going to
Okay.
talk. And,
Okay, all right. So I'm kind of the radiation piece, and so my plan, you know, from a radiation standpoint, depends a little bit on the surgical standpoint.
exactly.
But in general, just to kind of give you kind of big picture, kind of what the role of radiation therapy is for mucosal melanomas. So for melanomas of mucosa, wherever they pop up, anal canal, vaginal, head and neck, a lot of times we do recommend post-operative radiation therapy. And the reason being is that these are hard to get out with wide enough margins where we feel confident that the risk of them coming back where they started is really low.
Right.
You know, a lot of times in these sensitive areas, we excise them, but not with wide margins. And so radiation is often added to the paradigm to reduce that risk of a local recurrence. And so for anal melanomas, we commonly do recommend radiation to the anal canal itself. We don't treat the lymph nodes. There's no benefit to the radiation for lymph nodes, but we just target where the tumor started. And that's for patients who have just an excision.
Right.
If there was a need for a more aggressive surgery, oftentimes radiation is not necessary. I don't anticipate that being the scenario, but you know, if the plan is just an excision with this, leaving the sphincter intact and the anal canal intact, then we would recommend postoperative radiation. And again, that's to reduce the risk of a local recurrence. In terms of the timing of that, that generally happens once you're healed. Usually that falls somewhere in the ballpark of 6 to 7 weeks after kind of the excision, where we think about starting the postoperative radiation. The way we do radiation here is probably, you know, if you get a recommendation from a radiation doctor back at home, they probably would do a different regimen. They probably would still recommend it, but do a different regimen. So we do a melanoma regimen that's kind of known as the MD Anderson regimen. It's used pretty widely, where we give, instead of giving kind of a low dose every day for a lot of days, we do a higher dose per day in 5 treatments over the course of 2.5 weeks. So 2 treatments a week. So we usually do a treatment on a Monday and a Thursday, or a Tuesday and a Friday, for a total of 5 treatments. Like I said, the target is the anal canal. We don't chase the lymph nodes. We don't treat up into the rectum. It's pretty focused radiation. It does have side effects. It's a sensitive area, so usually you get through the 2.5 weeks of radiation pretty easily, and then the next 2 weeks suck. Yeah, it's like a sunburn, and so the bowel movements get sore, painful, frequent. The radiation causes increased bowel movement, so I expect more frequent bowel movements, and sometimes just the urgency, like you feel like you gotta go, but nothing happens. It's just a sensitive area. Usually within about 2 to 3 weeks of finishing radiation, things are getting pretty much back to normal. And then that's usually when the adjuvant systemic therapy, either with immunotherapy or chemotherapy, starts. We don't like to do chemo at the same time as radiation, but if Dr. Diab wanted to get immunotherapy started, that's okay.
Okay.
And again, we'll have kind of that conversation behind the scenes, but
Sure.
That's in general kind of the big picture plan. Radiation typically we do recommend, and we just kind of have to sequence that with the surgical plan.
So if it's like 2 days a week, like what's a typical thing? You come in and sit in the chair and
Yeah,
just
yeah,
kind of
good-
like
yeah,
IV
good
you,
que-
or
good
how
question.
does that work?
Yeah, so we start by doing a planning session. So where we lay you in the position that we want to treat you. We make a mold for your kind of hips, thighs, which will hold you in the same position every day. And we do a quick CAT scan, no contrast. Once we do that scan, it takes us a week behind the scenes to plan the treatment. And then you come in, each of those treatments, you lay on basically a CAT scan table in that mold that we've made. A machine rotates around you. By the time you're dropping your car off we have our own valet entrance, free valet for patients on treatment, to picking it back up every day, it's about 45 minutes a day. Time on the radiation table is about 15 to 20 minutes a day. Radiation's being delivered for about 7 or 8 minutes.
Yeah.
It's like an x-ray. You don't see it, you don't feel it, you don't smell it, you lay there and it happens. You notice the effects kind of that last week and after, but the treatment itself is pretty straightforward. I mean, it's easy to tolerate.
Okay.
Questions?
Other than like the sunburn type feeling or anything, is there any kind of nausea or anything or is that more the chemo side?
Yeah, there's not nausea. So really the side effects of radiation are very much limited to where we're treating.
Okay.
The only generalized side effect that we really expect is fatigue. That happens for everyone. It knocks you, it's the type of fatigue where you wake up in the morning, feel good, you're able to do what you want to do, but kind of middle of the afternoon you hit a wall.
Yeah, like I'm done for the day.
Yeah, you take a cat nap or whatever. That's usually the only generalized side effect. We don't expect nausea, vomiting for this area. Sunburn, discomfort with bowel movement, some frequency with urination, because we do our best to avoid the bladder, but it's right there.
Yeah.
So you'll be peeing more frequently. Sometimes patients notice a little bit of burning with urination, like a urinary tract infection.
Right.
Those are the main things. In the long term, so sometimes the bowel movements are always a little bit more frequent. There's just a little bit more urgency to when you gotta go, you gotta go. You can't hold it for as long.
Right.
Occasionally there is a little bit of an issue with continence. So sometimes, leakage, if you're not quick to go to the restroom.
Right.
And then the other main thing, that for you that I'd be worried about is fertility, impacting sperm counts both in the short term and the long term. So that's something that if it is important to you, it probably is worth thinking about sperm banking.
Right. Okay.
So
that sunburn feeling, is it painful? Like it feels like a sunburn in that area. Does it get worse as the treatment goes on?
It's usually that it hits a climax kind of that week and a half after treatment. And a lot of times we recommend sitz baths. You sit in a little tub of water with some Epsom salt or things to kind of keep it soothed. And a lot of times we do need to use pain medication because bowel movements become painful.
Right.
We get you through it. We do this a lot, but it's not a walk in the park. I mean, it's not the easiest type of radiation that we do.
Okay. Probably not going to work type thing. doubt
I
it.
mean, during those first 2 weeks of treatment, it's probably fine. You won't notice much, but that week and a half after, it's
yeah.
probably not. You're probably not going to want to be at work.
Okay.
To be honest.
And for how long then? Did you say so? Work.
I'd probably plan on being out for 2 weeks.
Yeah.
Okay, so the first 2 weeks would probably be okay, and then
Yeah.
the second 2 weeks be off completely.
Yeah, that's kind of how I would anticipate things going,
So
Yeah.
10,
with a little bit of flexibility.
Mhm.
But
Yeah.
yeah,
10 treatments over
2.5 weeks.
5 treatments
5 treatments
over 2.5 weeks.
Okay, wow.
So
That's
2
quick.
treatments a week.
2 treatments a week. Yeah.
Okay.
Some places, if you go to UT Southwestern or whatnot, some places will do 30 treatments for this daily, like Monday through Friday. It's just we've historically, past 40,
Yeah.
50 years, we've done it. There's some preclinical lab data that shows that melanoma responds to higher doses per day over a short amount of time as opposed to
Little
small
doses.
doses, and so that's how we've done it forever.
Yeah, that sounds good.
And the radiation would be done here.
Yes, ma'am.
Okay.
I mean, that's assuming
Yeah.
you want to get it done here. If
Yeah.
you wanted to get it done locally, then that's, you
Regimen.
can meet with a team there.
No.
But if you're going to get it done by MD Anderson, it needs
Yeah.
to be done here.
Yeah.
Gotcha.
Is it in that outpatient building, the radiology outpatient building, or is it?
Yeah, it's an outpatient. It's technically in the building you're in now. It's just at the back.
Yeah,
So
so
it's
big.
it's so big. Yeah.
I saw on the map there was it said radiology outpatient.
Yeah, there's a separate entrance. But I'll have Mike or Diane come in and
So-
tell you kind of where to go.
Like if I didn't have any surgeries, how quickly would I start this, or is that something you'd have to talk with you
Yeah,
about?
no. So I think so. Your surgery was on the 16th. The
rectal one,
and
yeah.
so that was about 3 weeks ago at this
Yeah.
point. So I probably, depending on how everything sequenced, I probably would start thinking about treatment in beginning of September. Probably give you a few more weeks to heal. I'm not going to examine you. I know you've had a lot of exams
Yeah, yeah.
lately, but I anticipate, maybe kind of that first week of September doing the planning session and maybe starting the week after that,
Okay.
if that timing worked out for you, and also,
Yeah. Okay.
Doctor, I think he was thinking about doing more surgery.
Yeah,
at
if there
least in
was
the
a surgery,
groin.
then we'd have to wait like 6 to 8 weeks to heal again.
Yeah,
right?
we'd have to figure that out, because if there's more surgery to the groin and not the anal canal, I'm not sure I'd want to wait. The clock kind of starts with the surgery for the anal canal.
Yeah. So
And once we get much past like 10, 12 weeks post-operatively, the utility of radiation goes down.
Yeah.
So I don't think I'd want to wait for the surgery of the groin to fully heal. I mean, we'd stay off of that area, but I don't think that would impact the timing necessarily for treatment of
Okay.
the canal.
Okay.
Okay?
Sounds pretty
Okay.
good.
So we'll all talk behind the scenes, probably tomorrow.
Yeah.
And then, if the plan is radiation is coming up in the near future, we'll kind of reach out to you and,
Yeah.
and put that on the books.
Okay.
Like I said, looking at the calendar, I was thinking of maybe that Wednesday after Labor Day weekend doing
Yeah.
the planning session,
Yeah, like
and
the
then probably starting radiation the following Thursday or something like that,
Okay.
or Friday,
Yeah.
whatever works
Yeah.
for you guys.
Okay.
Yeah.
Okay.
Cool with that.
All right.
Beautiful.
So we, like I said, we'll be in touch. That's who I
Awesome.
am.
Thanks,
If you
brother.
guys want one as well, just
Well, sure, absolutely.
do you want?
I'm
you're
good. A question,
Yeah.
when he comes to do these treatments, is it recommended to like stay at like the Rotary House? Cause it's like impossible to get
Yeah,
reservations
so that's a good
or-
question. I mean, because we do this twice a week, and you're not local but semi-local, it's not unreasonable to go home. I mean, if we treated you at like 1 o'clock each of those days, I don't know if you drive in, drive out, but
Yeah, from Plano up in Dallas.
yeah, I
It's
mean,
about
so
He would
four and a
become-
half hour drive.
it's a long drive, but I don't think you need to stay in Houston if you're comfortable doing that traveling
Yeah.
back and forth.
Oh, yeah, yeah.
So it'd be like a
But
one night before, depending on what time the thingy was, and then.
I was just thinking like, cause it's a couple days apart,
Oh, right.
That you know,
You might want to be at home.
Yeah.
maybe you do.
And as far as the travel in a car, will he be comfortable enough
Yeah,
traveling?
I think so. I mean, that last that last treat, kind of that last week.
Yeah.
If you want to stop at Buc-ee's and
More
plan more frequent stops,
Woody's.
that should be okay. But yes, I think traveling in a car will be. I mean, it's not going a little uncomfortable that last week.
Yeah. Okay.
But bring a soft pillow to sit on.
Yeah. Should maybe have some meds or something.
Yeah.
Right?
Yeah, and definitely we'll kind of manage
It'll keep
that.
you comfortable, yeah.
Yeah.
Alright.
Okay.
All right.
Yeah. We went over the sperm thingy, which was on our list. So.
Yeah, I would. I would think about it.
Yeah.
I probably would do it.
Sure.
Just in case.
Yeah.
And the timing and the side effects, we got that. Anything else, Chris, you can think of?
No, it's on my head.
Okay. So everybody will rally and convene with Dr. Diab, and so
Yeah.
we meet with him tomorrow.
Yep. Yeah, the conversation's already started. Email to all of us this morning. So we're all kind of starting to talk about it. So
Oh, that's
I just
awesome.
hadn't had a chance to meet you.
Yeah.
Had a chance. So
Yeah.
neither of us had weighed in, but
Sure.
tomorrow there should be a pretty more firm plan.
Okay.
Okay.
We're meeting with him at noon, so.
Yeah.
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 Okay.
All right.
Okay.
All right, sir.
Nice
Thanks,
to
man.
meet you.
All right.
Usually, for most people, a lot more than just a sunburn. Can get quite raw.
Oh, really?
Can have some looser stool. For some people, just looking at the box of Imodium sitting on the shelf
Will
will
make you
help
wanna
to.
go.
No, will get you
Oh.
get you slowed down enough. Some people actually need to open it up and smell it, and some people need to take upwards of 8 pills per day to slow down.
Right.
It just depends. I know that. I know what to look for. I know what cues to take from you, and we get you taken care of. Okay?
Gotcha.
So don't let that piece worry you too much.
Okay.
Any of the skin reaction is not going to come on until
Afterwards.
pretty much after you're done.
Okay.
You may have a little bit in last little bit of treatment.
Right.
Most of it's when you're done.
Okay.
We can talk through just about anything on the phone.
Yeah.
I've gone so far as to have some people take pictures and send them to me.
Yeah.
It's not really necessary, but if it makes you feel
Okay.
better, have
You
at it.
gotta see what I'm talking about. Believe me, it's real.
One guy even asked, I was like, man, I said, your arms aren't that long. Who took that picture for you?
Don't tell me, I don't want to know.
You know?
Oh, wow.
But yeah, those types of things are going to happen.
Yeah.
It will be uncomfortable for
Right.
probably about 2 weeks after you're done.
Yeah.
I'm going to say it's going to happen because I'm the one that usually deals with most of the folks afterwards.
Yeah.
You know,
Yeah.
I'm your point of contact, so I'll be the one that talks you through it
Okay.
and gets things taken care of. So, yeah, that's something that I see with most people.
Okay.
Something that's debilitating or anything like that. No.
No. Okay.
No, you can still function. And depending on when your treatment falls, yeah, if it's in the end of August or into September, sometimes even October down here and it's nice and warm, yeah, it's a bit more uncomfortable.
Yeah.
If it started to cool off, it's not as bad. That does
May
play
factor.
into what I tell you is going to happen or not happen.
Yeah.
But once again, another bridge that we cross when we come to it. None of the side effects that will hit you will start day 1 or day
Yeah.
2 or day 3.
It's always after.
We can talk through everything as it's coming. It's not something that you're going to wake up with one morning, like when you got your braces tightened and say, oh God, why did I do that? It's something that's going to come on gradual. You're going to start noticing things. You're going to let me know about it, and we take care of it.
Okay. That's awesome.
Yep.
No worries.
Yep. So nothing that should really catch you off guard.
All right.
All right. Any
Sweet.
questions from that?
I don't.
All right.
No. Just take it as it goes, man. See what's
All
up.
right. Very good. Well, go and recover from today's proceedings.
Yeah. For sure.
But my number's right in there. If y'all do
Gotcha.
think of any questions, I tell most people the best place to think of questions is whenever you put your hands on the steering wheel in the car heading home. You're like, oh, why didn't we?
That's what we do.